Hi, today's February 13th, 2023, and I'm honored today to be joined by Professor Barak Richman from Duke University. He's a professor of law, and he's got a PhD in economics, and I believe he's a professor of business as well. And he is here to talk about problems with the healthcare system. And take it away.
Thanks very much. I guess where to begin?
Yeah, just why don't you start with fixing it, and then we'll go back from there.
Well, I mean, I do think that I have a pretty parsimonious critique, which is that we get most of our care from the wrong people in the wrong places at the wrong time.
Yeah.
We have a healthcare system where the hospital really is at the epicenter of the delivery model. And in fact, what would be preferable is to have the hospital at the periphery. We want it as a destination, not as an anchor.
Huh. I like that. That is interesting. So can you perhaps frame how you have concluded that is the issue, and how did we get there?
So, I mean, I think those are related questions. So, we often did have the hospital as the place where we would only take care of severely ill patients. But our interventions got more sophisticated. We would always pay more for services that are in the hospital than services that are elsewhere. The theory behind that is because hospital services are more complicated, more costly. But as the hospital became more of an economic generator, there was a recognition that the hospital had the highest potential for revenues. And hospitals started to purchase other hospitals. They started to purchase physician practices. And instead of having the hospital as the place where we would only go for really serious care, it began to be the place where all care was funneled through. So you could say that we started down a technological path where the hospital previously was only for exceptional care, and now it's for almost fairly routine care. And the hospital also became the conduit or the controller of all referrals and managed to self-refer, to channel patients to the place where care is most expensive. So I really think that it's going to be very hard to do anything about that. But what we need to do is really tether extract the tentacles that the hospital has over all other areas of care and really make sure that we focus on primary care, preventive care, outpatient care, maybe not even care at all, maybe investments in preventive behaviors, investments in healthy communities. We've got to redirect all of our economic resources away from the hospital and towards higher value care, and make sure we only use the hospital when we really need it.
So I get that, and I have some my own. I like to do analogies, and I apologize, but I'm wondering, why we have this, kind of issue. I think it's kind of a consolidation. It reminds me a little bit of how Germany formed. There were all before. It was kind of a late forming state in the 19th century, and there were all these dukies and viscounts or whatever, running place and so forth, these little fiefdoms, and they kind of agglomerate, try to take the surrounding areas, and then there's allegiances and alliances and so forth, and kind of empire building. I feel like it's a little bit of like a board game, Stratego. I'm not sure I have the right game. Anyway, where you kind of have to, take over the world a little bit.
It's a game of Risk, yeah.
Risk. I don't know why I said Stratego. I apologize. But it feels that way a little bit. I've seen over the years, I've been, practicing in Massachusetts since '83, and, hospitals, they kind of get branded up, and never the opposite. So there feels a little bit like this kind of mutual adherence. And I assume there are some, economies of scale, and it makes sense on that level. But the analogy I was going to, bring up is why we don't have this. Is not my original to me, but I heard this a while ago. Why don't we have kind of a crisis in, there's health insurance, and why don't we have a crisis in car insurance or home insurance and so forth? What makes health categorically different a system, and how did it get say, so kind of insulated from market forces?
Yeah, I mean, that's an interesting way to put it. So this consolidation process began really in the 1980s, and it began on a fairly local scale. Your description of risk, how Europe consolidated, Germany consolidated, then Europe consolidated, then East Asia consolidates, is fairly apt. And it began with the simple recognition that if two hospitals could jointly negotiate with the local insurer, they would be able to get much higher prices. I mean, maybe it began uh, with the effort that insurers had and payers had to try to control price inflation. I mean, previously, we would just pay doctors and hospitals whatever they thought was reasonable. And when there was some kind of counteraction by either large insurers or maybe even Medicare trying to stem the price inflation, physicians and hospitals tried to react by organizing and creating market power. So that kind of, you might say, was kind of the beginning of this accumulation of power. Now, I don't think there were really any scale economies. I mean, I don't think the evidence suggests that when two hospitals merge, they can provide either higher quality care or lower cost care. And that question has been studied fairly thoroughly, but they sure can negotiate for much higher prices.
Mm-hmm.
And once that local monopoly power was leveraged against payers, mostly insurers, that really significantly increased the price of health insurance. And when health insurance gets more expensive, fewer people can afford it. And that's how we have an insurance crisis in the health sector, but not in the auto sector. Auto insurance, the cost of auto insurance really is always a function of competition. And in most markets, you can get auto insurance from lots of different providers. And the cost of auto insurance is basically controlled by, I don't know, the cost of accidents.
I actually think
I
apologize for disagreeing so early, but I kind of feel as if there's another aspect to it. Automobiles, we care about our cars. I care about my car. I sometimes I fall in love with my car, that kind of stuff. But if it has a crash, I do not. I mean, theoretically, hopefully, I don't die. So the car can absorb literally and figuratively a lot of our cushions and so forth, a lot of our accidents, without necessarily transmitting them to us, especially now with airbags and whatnot. So the car gets broken, we get a new car. We get broken, we don't necessarily get a new we, or us, or me, or you. And so there's a little. It's one step removed. But I think that the bigger issue is that we are much more apathetic towards other people's cars. And we don't necessarily worry about kind of the group health of cars in general. We don't worry about the risk factors to other people's cars because they are, encompassing themselves. So I don't worry about, I might worry about salt on the roads and so forth, but not as a general concept. The same way, people might worry about, I don't know, smoking in the air, that kind of stuff for humans in general. There's not really the public health aspect towards automobiles in the same respect for their longevity as we care about our own longevity, A. And B, we have a kind of a buffer in what I call the parental model of medicine. It's not like, I get to buy my car, I get to buy my next car, I get to trade my car in when I like, I get to buy two if I want one for sport and one for the winter, whatever. I can do a whole bunch of things with my cars, and it really doesn't affect you or anybody else per se. But in the health sphere, I pretty much only can buy the things that are approved by my parent, in this case, my physician, and potentially, in concert with the insurance and so forth. So I'm not a free acting consumer. So I'm wondering, if you can address some of that, and if there are any kind of changes or fissures or things happening along that regard where people are getting what I call the consumer moment, that impetus to do something on their own and for themselves.
So, there's always a danger in pushing a metaphor a little too far.
Yeah, I do that a lot. I apologize.
But actually, when you are a beneficiary of an automobile insurance claim, if somebody hits your car, or even if you if you injure your car yourself, you actually can't take your car wherever you want to. The insurer pre-negotiates with places that they think are of high quality and of low cost, and that's where you take the car. And the car, it's very rarely to the closest place, and it's almost never to the most expensive place.
Mm-hmm.
But because the auto insurer pre-negotiates. They know that there are going to be a certain number of claims in a year. They pre-negotiate these terms with auto body shops in the area. They're able to negotiate in a free market where there are lots of offers and lots of providers. The market works to keep prices down.
Mhm.
You can imagine health insurance working the same way. Look, I have a handful of knee replacements, a handful of heart surgeries, nothing emergent, of course, but most care is not emergent. A bunch of, I don't know, a bunch of liver replacements. You can imagine all that happening in advance with a competitive market. But what that would probably mean is that you might have to go to Oklahoma for your knee surgery.
Mhm.
Now, is that a terrible thing? Now, I will say that we're now adapting models like centers of excellence where we are becoming more accustomed to traveling for care. And by and large, that care model really works, not just because you're going to places that are real experts in the particular service that they're doing, but also the way the contract works, they will not give you unnecessary care. It's more of a per head per month kind of arrangement where if you don't need the surgery, we'll give you physical therapy instead. That's not the way we pay for healthcare. I mean, if in fact we were in a situation where we were told to go to Oklahoma for the knee replacement, for the most part, that's something that we would resist. I don't think it's a rational thing to resist, but we had this deep attachment to our local hospital. There's a fear of traveling, and the hospitals know this. It's very, very hard to market an insurance product without access to the local hospital for pretty much any kind of service. If it were easier to market those products, so-called narrow network plans or center of excellence plans, we'd have a much, much more competitive marketplace than we do.
Hmm.
We don't. Now, another feature, and this is another big difference between health insurance and auto insurance, is that for auto insurance, we pay out of pocket. We know exactly what the price is. We pay it in full, usually in either installments or one big check. We know how much it is. And we usually shop around before we buy it.
Mhm.
For health insurance, we don't know how much it is. If you are getting your health insurance through your employer, and about, I think his number is about 155 million Americans, you figure that's about 70% of the workforce, of the non-retired workforce, gets their insurance through their employer. You don't know how much it is. You pay a certain amount when you elect to enroll in the employer's plan, but the employer pays for the majority of it, usually about 75%. They take it out of your wages, but you don't know how much it is. So we're also just not nearly price sensitive for insurance either. And by the way, I think that we would go a long way just by making sure that individuals knew that every dollar of health insurance they're getting is dollars coming out of their pockets. And even with the tax exclusion, I think that that would go a long way, not only in reviving some competitiveness in the insurance market, but with a more competitive insurance market would mean more selective and more competitive healthcare services too.
Well, that's a great point. I think it was Senator Phil Gramm back in the day who had the idea of the health savings account. I mean, probably wasn't his idea, but it got popularized, and they wanted to have kind of the high deductible plan, so people would, take some interest in their actual prices of what they're buying. I mean, it doesn't really happen, with clothing. I buy what I want. I try to find the price point, so forth. But with healthcare, you don't really have the opportunity to shop. If you call a place and you don't, there were times in my life, in my kids' life, and so forth, they weren't insured, and then you spend a lot more time. This is me as my 20s, where you spend a lot more time calling up and getting prices, and it was the offices are very a lot of times I don't even know. I have no idea what the price of something is. It's kind of a weird thing.
Yeah.
And they don't really feel like they're selling it. And if you do, if you're a cash paying customer, a lot of times, if you go to the mechanic or whatever, you say, "Oh, there's $500." Well, how much? How if I pay you cash? Oh, $400. But with physicians, it's the opposite. It's like, how much is it? It's like, $250. Well, how much if I have no insurance? Oh, it's $1,000. And it's a craziness because you're buying into in a sense a club, and the club members get to go in and out all the time. They don't really think about it and whatnot. But you just want that day pass to the club, and the club charges whatever it feels like. And if You know,
Again, we don't want to analogize too much. Healthcare is different. We will pay for, for emergency care, we will pay for anything. There's also, this is something that I, as a non-physician, appreciate more than you as a physician. There's also just a whole lot that non-physicians don't understand. There's a lot of agency that's lost in purchasing, and I think no one could credibly say that that non-physicians, maybe even physicians, could be reasonably intelligent consumers of healthcare. I don't think that is just a credible claim. So we're always talking about a very complicated market where coming up with a good solution will be always difficult and always have some kind of inefficiencies. Now, if we think about what some of those costs are, or some of the benefits and costs of different arrangements, we can compare a health services account with a high deductible health plan. The basic idea is that most things go out of pocket. Some things are not. The problem with that, of course, is that means that everyone's very price sensitive, and they won't purchase things that, for the most part, seem to be pretty valuable in the long run. You can imagine, by the way, you have to pay for a yoga class, but you don't have to pay for back surgery. Well, we have the wrong incentives. And that's exactly what happens, by the way. We have to pay for our yoga classes, even though it might really lower the total cost of healthcare for us and improve our well-being down the road. Insurers, we think, are going to be good proxies for us. We think that they're going to purchase the kind of services in advance that we might need. Mm-hmm. We all need emergency care. I mean, that's really what insurance is. Mm-hmm. But we also would really benefit for some preventive care that both improves our well-being and reduces our long-run costs. Certain tests, certain screenings. But insurers also are bad proxies. We might be fairly good at purchasing insurance, but we're not really good at monitoring our insurer's purchase of care for us. And part of the dynamics of a local monopoly, is that an insurer basically has a choice. Either the health insurer can say, I will make sure you have full access to the local monopolist. It's going to cost a lot. The monopolist is going to charge a lot, but I'll make sure you have full access to it. And by the way, the monopolist health system tends to give me a little bit of a kickback also. Or I can invest very heavily in sending you to this place for knee replacements, this place for back surgery, this place for cancer care. And that's just a lot more effort. And it requires really scrutinizing the efficacy of care and the value of care from different places. It involves scrutinizing the kinds of services that are high value versus low value. And we don't see a lot of insurers investing in that kind of effort. So when we purchase insurance, we are asking for help. We, the patient that doesn't know what care we need or even what care is valuable, we're asking for insurers to help scrutinize that for us. But insurers have their own economic incentives. It's not just to deny care and save money for them. In many ways, actually, the greater incentive and the greater danger is that they'll pay for everything, but just charge us an enormous premium and secure the marketplace and share the monopoly profits with the local hospital.
Yeah, so you have to wonder who's the product at that point.
That's a very good way of putting it. Yeah, I mean, we would think that the doctor is providing the product for the patient. In many ways, the patient is the product for the health system, and then the insurer is delivering the product.
Well, it's going to be probably going to have to rewatch this to fully wrap my mind around that concept. But yes, I think there's something there. I'd like to maybe touch on your article in Politico. I mean, we've been doing that a little bit, but do you want to maybe just kind of give a broad overview of what that was and what it means?
Yeah, so I wrote that article out of a little bit of frustration. So those of us who have been studying antitrust have been a little dismayed at ineffective antitrust enforcement. And those of us who study antitrust in the healthcare space have been extremely dismayed at poor antitrust enforcement. The process that we talked about before about local hospitals joining forces, merging, a lot of that shouldn't have happened. A lot of it under basic application of antitrust law, should have been stopped. But it wasn't. And antitrust law, for a variety of reasons, is too complicated, it's too costly to enforce. People thought that hospitals are run by good people for a bunch of reasons. We didn't stop that consolidation from happening. Now, as you know, there's more of an antitrust furor going on in Washington. The president keeps putting competition at the focus of his healthcare, of his economic policies, including healthcare policies. Much of the healthcare world is very disturbed at the accumulation of economic power that hospital systems have had. And fairly recently, there's been a collective turn to the antitrust laws. Said, help us. Or sometimes they even say, why haven't you been helping us all along? So the frustration I had is that, there have been some of us who have been saying this for a long time. I have to say my predecessor, Clark Havighurst, he taught antitrust here at Duke for about 50 years before I showed up in 2003. He had been among those who had been urging use of the antitrust laws in the healthcare space. And in response to the plea, please help us, the answer is it's too late, really. I mean, it's too late for the easy stuff. Most hospital markets are already consolidated. That is, in most municipalities, most local hospital markets, most of the major hospital systems have already merged. Or if there are 2 systems or 3 systems, they've eaten up all the other smaller hospitals. And the most obvious and the easiest antitrust intervention would be to stop hospitals from merging. That's a lot harder to do if they've already merged. And in many ways, it's impossible to do if they've been merged for a long time. So what do we do now? So the antitrust, so the piece in Politico, one part of it was, let's capitalize on this new fervor in antitrust law. It recognizes and it expounds why the antitrust fervor is here to begin with. There is lots and lots of evidence to suggest that when hospitals merge, quality goes down, prices go up. In fact, prices go way, way up. Hospital monopolies, I think, are among the most lucrative monopolies there are. It really is hard to, you can do without certain goods, but you really can't do without an insurance product that gives you emergency care at the local hospital. So hospital monopolies are very lucrative. They've been extracting wealth from communities all over America. They've been the leading contributor to rising healthcare costs and why we now spend $1 out of every $5 in healthcare. So the article acknowledges why we are now concerned, and the article says we really should have intervened a long time ago. But then it tries to lay out a plan for what we can do next. Mm-hmm. And I think the best approach, the main message the article offers is the point that I began our conversation with. We've really got to detether the hospital from the rest of the healthcare system. Mm-hmm. And the new wave of consolidation has involved hospitals, not just buying other hospitals, but hospitals buying physician practices. Yeah. And without a source of independent physicians, the hospital really can call all the shots in our healthcare system. We really need independent physicians, perhaps to direct people towards more affordable hospitals, perhaps keep people out of the hospital through preventive care. But what we have now is if hospitals control physician practices, they control patient flow, they control referrals, and all of us are sucked into the hospital. So the first thing I think we need to do is to preserve independent physicians. It means preventing hospitals from buying them up. It might mean requiring the extraction of physician practices from health systems. It certainly would mean pursuing a whole bunch of policies that would allow the encouragement or support the development of new physician practices. Mm-hmm. But it's the kind of thing that antitrust law hasn't really thought about. I mean, they think about stopping big mergers, and maybe what we really need to think about is how to stop small mergers and how to rewire the delivery system that we're falling into.
Well, it's an interesting point you make. I mean, I remember when there was Ma Bell, AT&T was broken up, and up came MCI and Sprint and so forth. I don't know if it was the 1970s or something. uh, in this case, it's not really a national hospital company. I mean, I think there are some cross-state companies, and there are some probably national companies, but it seems to me like a kind of almost like the NFL. There's like regional franchises, So Kansas City might have one set, Philadelphia, the Super Bowl.
Did you have to bring that up? Ah,
different set.
that happened yesterday.
Yeah, that the Eagles played really well, by the way, um, and so there's a system in Boston. So, but if you start breaking them up just by city, then doesn't that leave the places between cities as having had some kind of unintended benefit? Kind of jacking them up. Well, here we have Mass General, Brigham Partners, whatever, but all the Harvard systems kind of annealed. And I think there's still, Tufts and Boston University and so forth, other systems extant. But it's not as easy as just kind of going into AT&T and slicing off a few appendages or organs or however you want to look at it. But in this case, I mean, how do you do it? I'm not sure how many municipalities we have more than 500,000 people, but let's say there's 30 or 50 or whatever the number is. How do we do that and be equitable, as it were, to and plus it just seems like an enormous task to kind of duplicate the same thing as opposed to being in one company. I don't know how do you do that, and how do you actually claim antitrust when it's so regional and molecular in a way?
Yeah, well, I mean, there was a time when we could have facilitated lots of regional competition. Yeah, I mean, look, and that's to a large degree what they have in some other countries, like in Germany. Lots of local insurers, lots of local providers. And there's reasons they can do that there more easily than what we have here. But because this is not like Ma Bell, where scale economy was so important. I mean, if you weren't attached to Ma Bell, you couldn't talk to anybody. But hospitals aren't like that. So we could have thought of ways to manage a lot of local competition. But I like the way you phrased the question. We are in a technological moment right now where telehealth, and I don't just mean, I have a runny nose, can I get a prescription? I also mean hospital at home care. I have acute care. I need long-term care, but I can have it in my home, which, by the way, actually means I avoid all sorts of mistakes and infections also. It might be better quality too. But we have ways we can do this. There are, especially since we know that bricks and mortar care is so expensive, and community-based care, that is care that recognizes that so much of one's health outcomes is determined by the community, can be so effective. We can come up with alternative models that rely on very little upfront costs, mostly personnel, not big complicated buildings, a lot of virtual monitoring and communication. It would be a very different kind of health system. Maybe not just healthcare system, but health system that we can imagine. And that could have lots of competition, and it wouldn't require any kind of upfront investment that would justify a monopolist.
Yeah, no, I think there's all the elements of that. One of my hats, I'm not wearing any hats right now, but one of my hats is angel investor. And over the years, I've seen a lot of, innovative companies. They don't all succeed, but they're all chipping away at kind of the monitor itself. I'm sure there's another word for this, but people basically use the word agency earlier. We're not talking about insurance agencies, but the agos, the self, and taking back control of the things you have. And we all have these amazing sensor computers we carry around, and there's you can very easily centralize a lot of the data and the inputs. Octopi have 8 arms. We have many more of those kind of tentacles to suck in and pull in data from lots of different sources. Our Fitbits and our diet, our calories we're taking. There's a lot of apps and so forth. And when they make this kind of mega app, it is in a sense you. I mean, your phone can kind of or your watch or whatever, it can tell how well you slept, and if your heartbeat's weird and so forth. And there's a way of they're going to be, I think, kind of getting another analogy. Like ADT or something monitors your house. There's alarms and so forth that things get tripped because it has sensors and so forth. It has a central processor, and it has to, in a sense, discriminate between the cat walking and a burglar walking, and then make a decision tree. And so to the police, you might have gotten 5 calls in the last hour. The police might ignore this. Anyway, so there's a lot of sensory stuff that needs to be kind of separated out. But at a certain point, your health record that the hospital has, and I think that, mind you, they're doing a much better job of it. Some of it's been forced upon them, and some of it's been their own initiative. But one of the nice things is that there's not as much duplication of tests. If you cross hospital tracks, I mean, yeah, but even so, there's HLA7, I think it is, whatever, and there's all these kind of ways of organizing. And I think at some level, the telehealth part, and the chat GPT, and a lot of ways of getting health information can be brought down to personal level, and it can become more like my ideal of shopping. It doesn't sound like much, but shopping's, I don't care about shopping as much as my wife does, but it is an interesting phenomenon, because there is a lot more responsiveness from the providers. They get better and better year after year, and you don't necessarily see that in healthcare that much. I don't know. Do you see any hope or prospect for kind of this, I suppose, a little, kind of grassroots approach of fixing things?
I mean, I think that grassroots approaches are necessary. I don't think that the article has a line where, the only way you're going to stop Microsoft is by encouraging the development of a Google. The only way you're going to defeat this hospital-based system is by having a totally different player in the marketplace. It's not going to be by, trying to curtail the power of the
hospital. I remember reading this on one of your pages, and I really like that analogy. It's not that, it's not that, opening up Microsoft. I think you had an article on, the antitrust aspects of Microsoft. It's not to break up Microsoft per se. It was to allow, other things that are not necessarily the classic desktop browser to be, actors in this same field. And I think that was a really interesting point, because we, amongst all the things difficult to predict, the future is the hardest. And we didn't necessarily see the cloud coming, although clouds, I mean, sometimes you can see them, sometimes you can't. But there's other ways of kind of disintermediating a certain actor by having things come up that you didn't have any idea. I mean, one of the competitors for the automobile is Uber, and they don't sell any cars, but they sell the act of being in a car, and that may be all that some people need. They just need the token, no pun intended, car now and then. And it may be that way with healthcare, certainly for certain age groups and whatnot. My younger son, he's a healthy guy, but he's finicky. He's a great individual. If you ever watches this, I'll use him as an example, because he was getting health care. He's getting health insurance, part of his job, and he works freelance, but he works for a company also. So he's getting health care, and he's frustrated because he's having to pay so much out of pocket. So he investigated on his own how much it would be if the employer just gave him the cash. And he's in his 20s, so and that happened. And now he's hunting for certain doctors. He's still finicky, and he's still got things that whatever I wouldn't necessarily go see a doctor for, but he is. But he's doing this act of shopping, and he's having a hard time, getting actual prices, how much things are going to be, how much is just an intro visit, and how much is actually going to be to look at something. And it's a funny place, because he's nearly unique in this regard for the places he calls, apparently. But there is some aspect of it, because he's young, so he's computer savvy. He hunts, he looks at reviews, he looks at this and that. He researches his problem thoroughly, so he knows exactly what the doctor needs to do. And that's not that different from shopping for a car. I think shopping for a car can be daunting, and there's a lot of them, and we don't know how much to spend, whether it's a used car, whether you get this gizmo or that gizmo, and so forth. But people do a lot more research, and there's a lot more agglomeration of research, through Reddit and all these other kind of sites and sources and whatnot. And I think we could probably at this point, get some consolidation of opinion about stuff, and the development of AI is part of that. Anyway, so that the question I would have is, how does that intersect? Is there like a Microsoft moment for us now? I think you partially addressed it, but if you care to carry on that.
No, I think you're exactly right. I mean, we can't detether ourselves from the current system on our own. physicians and pharmaceuticals and all of the things that we eventually really do need are just not hardwired for us to be individual consumers purchasing things out of pocket. There is an enormous need for some new kind of intermediary. And I think there are some insurance products out there that they're all app-based, they're geared towards young people who are very savvy, and they would be exactly the kind of product that your son and many others would really benefit from. And it's not just a new kind of insurance product. It really would be a technological discontinuity from what we're currently having. And I imagine that, you know, angel investors like yourself are really looking for those kinds of intermediaries.
Mm-hmm.
So one observation is this is a great Google moment or Microsoft moment in the sense that there is an enormous possibility out there to capture current inefficiencies and develop a new kind of way of shopping and providing and paying for healthcare or health. The other analogy, which is exactly right, is that that's not going to happen without scale. And it's very hard to get scale when what usually happens is that these companies are either foreclosed from the marketplace where they can't get scale, or they're purchased by some of the big guys. You have United Health and you have Amazon and you have healthcare systems purchasing all of these startups, including, by the way, really innovative primary care deliveries. You could imagine, by the way, their primary care team would just come up with a really good way of scaling up using all sorts of digital technologies.
Mm-hmm.
So there is lots of innovation afoot. And lots of people, lots of very smart people are recognizing the problems we have and are coming up with really sensible solutions. The problem isn't a lack of innovation. The problem is trying to get the right kind of innovation to really disrupt what we currently have.
Yeah.
And yeah, as you mentioned, I mean, we didn't know what was going to happen after Microsoft, but what we did know, and I've spoken to people in the Department of Justice who brought the claim, what they did know is that Microsoft was stopping stuff from happening.
Mm-hmm.
What we have now are exclusive contracts, MFN clauses, preemptive purchases. These are all ways of stopping new innovations from taking hold. And that's a real target of opportunity. If we can stop that, that's a very good place to put our antitrust attention.
Yeah, sometimes ideas and scripts and whatever are purchased to bury them. I'm not sure how much that happens in this realm.
For sure, it might not always happen intentionally. There's for many acquisitions, there's a genuine interest in pursuing and nurturing the new technology. But for example, when a local hospital monopoly system purchases hospital at home technologies, how incentivized are they going to use to use it, or at least to scale it up?
Mm-hmm.
And their priority really is to keep their own beds full. There's much higher revenue margins for those beds than at home beds. So even if the intention really is to expand services and to help patients stay at home, they're not going to have the same kind of verve that an attacker would have.
Mm-hmm. Okay, so I'm going to, as we kind of round to the last, say, third or quarter of the segment, I'm just curious, because invariably people will say, why don't we just ditch the whole system? Why don't we just go to, national health system and be done with all this, mishigas, which is a technical term.
Uh-huh.
Yeah.
I mean, it's not clear how you would ditch it. I will say that the national healthcare system in London has enormous problems, but they provide much more effective. They have much healthier population than we do. They spend much less than we do. How did England get to a national healthcare system? Well, World War II destroyed the system that they have. So, all right. So there at least is a precedent for being able to build something anew often is better than trying to improve what you have.
So you're recommending World War III then?
Yeah, but yeah, it's that's why I was precise with the way I said it. It was harder. I'm not recommending it. But we also have a real political economy problem. In a lot of places, the hospital is the biggest employer in town. It's enormously difficult to scale back the role of the hospital, let alone get rid of it. You have chambers of commerce, you have all sorts of workers, you have all sorts of economic interests in communities thinking that the hospital is their economic engine, which is really tragic because hospitals eat up economic resources. They don't generate resources. They have enormously low productivity rates.
Well, that's a difficult thing because productivity is theoretically the their product is keeping us from being disabled, and so you don't necessarily see if somebody comes in healthy or they're functional, they get sick, they come back, they leave, they're functional. The hospital didn't produce anything, but it preserved that person's functionality as opposed to having him be a greater recipient of further health care, like having a massive stroke or something like that, theoretically.
Yeah, I mean, and if we're providing healthcare efficiently, then that would be a great analogy. But the problem is that most hospitals are providing care that that costs of about 1/3 of what they charge would be able to generate. Whether it's outpatient care, whether it's remote care, whether it's destination care, whether it's preventive care. So the bigger the hospital personnel, not necessarily translate into more healthcare services or more health productivity.
So
and precisely because, but precisely because any move towards something more efficient necessarily means that certain jobs are going to be gone, and certain wages are going to be reduced. Now, the economists would say, yes, I recognize that, but there are going to be a whole bunch of new jobs, and there's going to be all this new take-home pay. But those are all projections. You're not talking about real things that you're going to see go down. It's a very hard political argument to make.
Right. Well, that's the problem with building anything. It's like the construction time, or there's a big gap. I'm just curious. First of all, I would push back a little bit about whether Britain has all that great a system. I think there are a long
time since they've scrapped it and started anew.
Yeah, no, but even so, in the delivery of care, I think there's always going to be greater wait times. There's going to be less personable care, less personal care. I think we are in a difficult spot. It often looks as if we have the bad system, the more expensive system, but it's a little bit like NATO. Another analogy, a lot of places are free riding on our healthcare system. We produce the medicines, we produce the innovations, we produce all the new systems because we have a payment system. Absent our payment system, would there be progress? I mean, this is maybe a little off topic for you, so I don't know if you want to just pass on this one. That's fine.
I mean, it's actually even worse than what you're describing. A lot of the innovations are coming outside the country, but they're targeting the U.S. market because that's where drug prices are high. Right. So the innovation is happening in India and in China, in Japan, and in Germany, and a lot of the returns of those innovations are going there. But it's our market that is driving a lot of that. And yeah, the analogy to NATO is not terrible. You could say that drugs are being developed because we pay so much for them, and then a lot of the drugs aren't any good, but a lot of the drugs are really good. And those drugs that are really good, the rest of the world benefits from also. And look, that's a complicated calculus. And it's one that I don't pretend to be very confident in what the answer is. I mean, I do think that we would be just fine if we were spending less for drugs. And I also think that there are some fairly naked anti-competitive practices in the pharmaceutical sector. But, the fact that new technologies are developed in this market is something that I think is a feature, not a bug of our market.
I agree.
And, I think it's easy to argue that many of those technologies are not worth the additional prices that we pay for them. I think you might even say, I'd be curious what you think about this. In many ways, because the American healthcare sector is so driven for driven for technological innovation, we sometimes don't think about fairly rudimentary low-cost innovations as something that we want to bring in. Like, for example, maybe there's a way we can use community healthcare workers to manage the mental health care crisis instead of drugs or other therapies. Maybe there are ways we can mobilize collective interventions instead of focusing on individual medicalized treatments. There's a lot of innovations that we're not developing
Yeah.
because they can only develop in a cost-constrained environment.
Yeah, no, so it's interesting, and I don't have a full answer for that. I will give you my, the seven blind men and the elephant. There's one piece of the elephant that various pieces I've massaged, so I understand, not the entire elephant, but at a certain point in my primary care practice, I started, the Suboxone came about through the DATA, the so-called Data 2000 Act, Drug Addiction Treatment Act, and it's supposed to kind of destigmatize narcotic treatment to take it out of the methadone clinics, which have a bad reputation, often very well deserved, and bring it to Marcus Welby, regular GP, outpatient, so forth, so people could just get their narcotic treatment there, and all well and good. And it turns out though that there's a problem again, which I consider kind of a market problem and a customer problem. Even though you can't really see a narcotic addict as a customer per se, but the market's distorted because most of those customers have they are on public assistance. So they all say they have insurance, but they actually don't have insurance in the sense that they're insuring themselves. They have state benefit, and whether it's kind of long-term Medicare, SSDI, disability, or short-term Medicaid, welfare, whatever you want to call it, they don't really care about how long, how much treatment, so forth, and they'll go in and out of detoxes and a lot. Maybe it depends on the person, but there is a model where certain of your high rollers, as it were, will kind of spin dry. That's their term. They go into a detox. They drop their dose down. They can save some money. They go back. They start doing it again. I had people who had been in like 12 to 15 detoxes within a year, and each one's like multiple thousands of dollars per. And $0 out of that person's, like literally $0 out of that person's pocket, even though that same person might be able to spend $200 a day on heroin. And so there's huge distortion. I mean, as an analogy again, there's a little bit, we have the public public colleges, public universities competing with private. If you go to a public college, I'm not sure whatever, I'm going to leave that aside for now, but there is, this aspect where certain of our consumers don't really care. And as a result, in my realm, the doctors didn't have any real incentive to turn the patient down on a dose. And there's what I call, kind of echoing Eisenhower's military industrial complex. I actually called it the methadone industrial complex, because the methadone industry, as it were, is very powerful, on a kind of lobbying basis. And it's effectively, I'm not saying they did this, but effectively, narcotic addiction over the years has become a disease, whereas it had not been into the 80s, I believe, and it became a disease. And therefore, the methadone or Suboxone is the treatment, much as diabetes, much as insulin is the treatment for diabetes. And so, there's this aspect where certain players can just mold the whole paradigm and mold the whole market. So, there's really, I was doing a gradual taper. I was giving people 3 to 4 months to taper off of narcotic because I wasn't really in it for the money. I like kind of sounds kind of crazy, but I like getting people, better. And it wasn't, my model was not there to make me a lot of money. I was just, a small time solo doctor and whatnot. But there was a lot of resistance around, and I'm not going to get too far into that, but it is kind of a distortion of market. You can't really have a market for narcotics if the people there don't pay anything for it. And they are really the commodity, as we were kind of alluding to earlier.
Mm-hmm. Yeah. And, the healthcare sector is replete with those opportunities. And either I think we can try to figure out how to curtail them, because you have people like the private equity geniuses that are figuring out ways to exploit all of them. Or we can come up with a different market. A different market structure with different market rules. And I'm inclined to move in that latter path. If we can figure out a way to offer competitive alternatives, avoid the possibility of exploiting monopoly power, avoiding the ability of any one entity of really controlling the referral network, and offering all sorts of room for new innovations and new delivery strategies.
Yeah.
That, I think, is the way to go.
Yeah.
But it does recognize that we're dealing with a very complicated industry that will always have lots of loopholes, and you hope people don't take advantage of all of them.
All right. Well, I think we covered everything on earth, healthcare related. I'm just joking. It's really hard to cover everything, but I'm certainly happy and honored that you were able to spend some time with us. I think it's a great gift you have. You certainly have an excellent comprehensive view. What would be the steps that people could do either to help you along in your vision, and how are you trying to affect that, and what do you recommend they look at or read?
Yeah, I think that the most important thing people can do is to engage with their employer and ask for low-cost insurance options. And that will always invariably involve an insurance product that does not send them to the fanciest academic medical center in town.
Mm-hmm.
And I'd encourage people to consider that.
Mm-hmm.
Encouraging your employer to be frugal, cost sensitive with your healthcare dollars, I think, is the first step. And probably nothing else will work if individuals don't put pressure on the offices that they have some relationship with.
Mm-hmm.
We really need employers to be better purchasers. We need more healthcare options for individuals, and that's probably the best way to inject some kind of receptivity of the marketplace for new ideas.
Well, perfect. Well, thank you so much. I always end my show with, in this case, something pretty unrelated, but this is my shameless self-promotion here. This is a book I've just finished, Overturning Zika. It's on the pandemic that never was. I'm not going to talk too much about it here because it doesn't really have any firm relationship to our topics at hand, but it is there. That was my commercial. I apologize. Anyway, you can stay on for a little minute, but we're going to say goodbye to everybody else out there. Thank you so much. And you can follow Barak Richman. I'll post his links to his articles. And maybe if you have any ideas on how he can help slay this dragon, that would be appreciated.
Ideas are always welcome. Thanks for having me so much.
Thank you. Bye-bye.